So first off, can you just explain your study of hospitals serving minority patients with regard to the following of breast cancer surgical recommendations?
Sure. So the reason that we wanted to do this study is because we know that kind of in the past, these hospitals that tend to serve more minorities do kind of have disparate access to care, and outcomes can be different in terms of cancer and other types of health disparities. And so what we specifically looked at was kind of the adoption of three clinical trials, the three that we examined in the study, the ACOSOG Z11 trial, the ACOSOG 1071 trial, and the AMROS trial. And all of these are kind of studies of omission of axillary lymph node dissection. So kind of doing less under the arm at the time of surgery. And these have all been kind of adopted by the NCCN and into guidelines. And so at this point, they're really standard of care treatments. And so we just wanted to see in the cancer centers at the that we had access to through the National Cancer Database, which is only cancer COC accredited centers, was there a difference in the uptake or adoption of kind of that standard amongst patients treated at these minority serving hospitals compared to kind of everyone else, so patients treated at non-minority serving hospitals? And our original hypothesis was actually that there might be a difference, just based on some of the other work that's been done around minority serving hospitals and racial disparities in general. But what we found is that for both of the ACOSOG trials, there was no difference. And for the AMROS trial, there was a small difference, but that really went away after we adjusted for some of the other confounding factors in the analysis. So we actually were, it was heartening to see that at least at the programs that follow COC standards that are accredited, care, at least these kind of standards of care are really being adopted at similar rates.
So what would you say are the implications of these study findings?
So I think that the implications for the study findings based on what we have so far is that when you think about where women should get care, and especially when care is becoming more centralized at specialized centers, certainly for minority women, obtaining care at minority serving hospitals, which are likely to be closer in their vicinity, closer to get to, they can be assured that they will receive, at least with regard to breast cancer, the standard of care.
So why is a study such as this one that you all conducted so important?
So I think that, as Dr. Cantor mentioned, there's been a lot of discussion about disparities in healthcare. We certainly know about disparities in access, in screening, and also in treatment and in outcomes. One of the things that we like to focus on, at least to eliminate some of those disparities, is in equivalent treatment, that for women who are of similar stage, regardless of where they go, they are receiving what we consider as the standard of care. And the fact that we can show that for COC accredited hospitals, they do deliver standard of care, regardless of race and ethnicity, that is at least one thing that we do know then that may help decrease disparities in cancer care. And so when hospitals, so the first question is, should hospitals be COC accredited? Based on this data, it would sound like, yes, they should consider going down that pathway, because there must be things in getting your COC accreditation that allows you to deliver optimal care and the standard of care to all women. So that's the first step. It's a little hard to make this generalization to non-COC hospitals as yet. That may also be the case. We don't know that, and we would have to do further studies to get a better sense of that. But for a hospital trying to determine how do I lessen disparities in healthcare, at least with respect to surgical treatment offered, it would appear that COC accreditation is one way to do that.
So are there any sort of planned next steps for the study?
So there are two plans. First is, trying to, as I said, we would really love to be able to see if we can make the same generalization about non-COC hospitals. And so looking at a population of hospitals that with the same profile that we just looked at, but they're not necessarily COC accredited, and see if they also show no disparities in care received. And so that's the first step. And I think that that's going to be the big question that a lot of people will have regarding the study, is it generalizable to non-COC hospitals? The second step, and we've also looked at minority serving hospitals with regards to their impact on healthcare disparities, would be, are there things unique to minority serving hospitals that may that give them characteristics that allow them to help address some of the healthcare disparities that we see, something outside of primarily the resources available, because that's one of the issues that has faced minority serving hospitals, is that they have less resources than usually non-minority serving hospitals, but paradoxically they take care of a population that usually requires greater need coming in. And so that has been proposed as a reason why we see increased disparities in minority serving hospitals. So our the second phase of this is we look at this particular question in other disease states, which is what we're doing, is are there things unique to minority serving hospitals that allow them to decrease this disparity in care that we see?
So how would you recommend that minority patients who feel that they're receiving differences in care advocate for themselves?
So the first thing is I always, and I tell this to patients who do come to see us, is that there are quite a few resources out there. And I think patients should take advantage of those resources because you want to, certainly the Society of Breast Surgeons, through their Breast 360 org, the American Cancer Society, these are locations where you can go and find out about what hospitals are in your area. And also they can tell you what hospitals are accredited. There's a national accreditation for breast cancer centers, what hospitals are COC accredited. And that gives you a sense of the overall level of care that the hospital around you can deliver, so that you're informed when you go into that hospital about what you can and cannot receive. And then the next step is when you meet your breast team, some questions that you may ask them to get a sense of, am I receiving the care that I should be based on what I've seen on these reputable websites?
So on the flip side, what sort of advice would you give to oncologists as to how they can ensure that they are providing the same care to everyone?
So I think from a health disparity standpoint, one of the things that we would like to see with regards to oncologists assessing the kind of care they receive is to do the same analysis that we have done inter-hospitals, intra-hospitals. And so that is one of the things that, in our work that we've also shown, and hopefully we'll be publishing at the end later this year, is what is that variation in healthcare disparity within your own hospital? Because you might not, you might not have the entire data for your region or for all the other hospitals around you, but even for the COC accredited hospitals, you can receive the data for your own hospital, and you have that data. So you can look at your own data to make sure that your disparities significant, or are they comparable? And I think that is one step that we can look at a health system level factor, at a systemic level, what you can do for your institution. I think individually as oncologists, we should push ourselves to make sure and to ensure that our patients are well informed, that we give them the resources they need and locations where they can get it, because there's so many resources out there. And I actually think some patients are bombarded with a lot of information. So I always have like 2 or 3 reputable sites that I like to send patients to, like cancer.org or Breast 360, where you can get some really good information about if you have the stage, if you have ER-positive breast cancer, this is sort of what you should expect.
Great.
Dr. Cantor, do you have?
So that's all I had for you guys. Is there anything else that you wanted to add?
I'll just add to Dr. Oseni's answer for the last question. One thing we know is that racial minorities are very underrepresented in clinical trials, and that's really true across all cancer sites, including in breast cancer. And so one of the standards of the COC that hospitals that are COC accredited require is that you have to enroll a certain percentage of minorities into the clinical trials that you're involved in. And so obviously it's important to have that representation so that we can see if the outcomes are disparate, even in women treated on the same clinical trials. And so that probably does kind of increase the overall, searching for the words, but I think the overall just acknowledgement of, the disparities that exist, and then the fact that these minority women were actively trying to recruit them to be on clinical trials. And so that may be, a piece of, some of this lack of disparity between centers as we saw. And of course, we can't quantify that in the type of analysis that we did, but there could certainly be a piece of that is translating into improved care. Absolutely.
And it helps us to be able to generalize the data that we do receive from these clinical trials to see if they're applicable to women of color as well.
Well, thank you both so much for taking the time to speak with me. I really do appreciate it.
Yeah, thanks for your interest in our study.